influence clinical decisions. Okay. So this session is essentially designed to help provide a practical, experience-driven perspective on how a 5-part differential can contribute to improve diagnostic accuracy, particularly when compared to the 3-part systems that some of us are used to, some of us know, some of us are conversant with, much more conversant with, and exactly what this means in our day-to-day practice, both for the patient, for the clinician, for the person requesting, and all of that. Okay, before we proceed, this session, we are looking at running it for 1 hour. We are looking at taking about 30 to 40 minutes for presentation, and then we'll have a question and answer session towards the end of the presentation. In case you have any questions, you can please drop them in the chat box. I'll take note of them and we'll respond to them either within the session or towards the end. Now, it's my pleasure to introduce our speaker, Dr. Oluwafemi Akinwunmi. He's a doctor and he's a consultant hematologist and head of laboratory at Marcelle Ruth Cancer Center and Specialist Hospital, Victoria Island, Lagos. Dr. Akinwunmi brings extensive clinical and laboratory experience in hematology, and we are delighted to have him share his insights with us today. You're welcome, sir. Over to you, sir.
Thank you. Good afternoon. Please, can you hear me?
So I can hear you, but I'd like all people who are here to respond.
Good to have you from here.
Okay, thank you very much. Please don't mind my background. Maybe if I'm able to get somebody to hear me, turn it the other way around. Okay. So let me share my slides now, and we'll take it off from there. Okay. Please, can you see my slides?
Yes, I can see it, but I would also like other people to.
Absolutely.
Okay. So can I go ahead now?
Yes, please, you can. And then don't bother about your background. We can actually see it the right way from here.
Oh, okay. Don't mind me.
Yeah.
Okay. All right. Thank you very much for having me today. I'm Femi Akinwunmi by name. I'm a hematologist. I work at Marcelle Ruth Cancer Center. I head the laboratory at Marcelle Ruth Cancer Center. I've had a bit of stints in the laboratory before coming to the clinical practice. I've worked at WellMed Healthcare before, 54 Gene, and also VK Diagnostics. Today, we'll be looking at enhancing diagnostic confidence, the clinical value of 5-part CBC differentials in modern medical practice. So we'll look at this outline. Why is a CBC necessary? For those of us that are not too used to the terminology CBC, it's commonly used in the Americas as CBC. What most of us know it as full blood count. So it's essentially the same thing. So if you see a CBC or a full blood count, it actually means the same thing. So we'll look at why a full blood count is necessary, the historical aspects of full blood count, how full blood count analysis had evolved over the years. We'll look at automated blood count. We'll look at the 5-part analyzer versus the 3-part analyzer. We look at the clinical value of 5-part differential. We'll also take a look at some real-world reports of full blood count analysis done using 5-part and 3-part analyzer, then we conclude. So as it were, full blood count or complete blood count is an important blood test that measures the types and number of cells in the blood. Let me say that a full blood count is a very fundamental test to every individual. There are different instances in which one would have to order a full blood count or CBC. In the most common instance is that maybe somebody becomes unwell, and then they present to the doctor in the hospital, and then the doctor, one of the most common tests that the doctor asks for from the lab is usually a full blood count. And you could have maybe a child presenting with a complaint, and then the doctor orders a full blood count. Or a situation whereby somebody has a chronic illness in which you need to monitor them, and then from time to time, full blood count is being ordered. In the most unusual way, or in the most unusual instances, when a patient actually presents very unwell, and maybe they have a very serious diagnosis, maybe something like a pneumonia, in which case the white cell count might be increased because of the infection. In some not so common situations, especially when it has to do with hematology, in which a patient present with unusual symptoms like bleeding, abnormal swelling in the body, then a full blood count becomes even more important. So as it is, there are several instances in which a full blood count becomes a necessary test to be done. In more maybe not so sinister situations now, we have a situation whereby people present for what we call annual medical screen. So part of the annual medical screen is also a full blood count. So a CBC is essentially necessary for diagnosing infections, detecting anemia, evaluating clotting problems, monitoring chronic conditions, or monitoring patients on therapies. Equally, a CBC becomes important in situations whereby there have been maybe an history of a past infection, then you want to follow up the patient, and then you have a repeat full blood count. Now, the body contains about 10 systems. Okay, we have the nervous system, we have the skin or integumentary system, we have the gastrointestinal system. So if you look at all these systems, for you to be able to take a representative sample from any of these systems is going to be difficult. Now, what makes a full blood count different is that it is probably the most easiest way to have an idea of what is happening in the body. Okay, so you just phlebotomize the patient, and there you go, you have a tissue sample. So for instance, if somebody has a breast lesion, you will need to get a surgeon, you need to book theater, you will need to, patient will undergo procedure, you need to give some form of anesthesia. So the full blood count offers an easy way or an easy ride or picture into how the body functions. And it also does not necessarily indicate a problem with the hematopoietic system alone. If there are other problems in the body, a CBC can reflect those problems in the body. So generally speaking, this diagram is showing a simplistic approach to the components of a CBC. All right, so we have the red blood cell component, as well as the white blood cell component and the platelet component. Now, the red blood cells, part of the parameters that are very important is the hemoglobin, all right, the oxygen carrying capacity of the blood itself. Then we have the hematocrit, which we will still talk about. Other derivative indices include the MCV, MCH, MCAC, and so on and so forth. For the white blood cell count and differential, of course, we all know the various differentials of the WBC, neutrophils, lymphocyte, monocyte, eosinophils, and basophils. And it is the bulk of what we'll be talking about today. And we also have platelets. which is mainly part of what is responsible for hemostasis, that is preventing excessive bleeding. So this diagram is a more comprehensive way to look at full blood counts, the importance, and so on and so forth. But let me quickly dwell briefly on some aspects of this diagram. If you look at the red blood cell indices, we have a number of them. Normally, when I'm teaching on a full blood count alone, I spend usually about 1 hour, but we don't have the time today. Okay, so I will just highlight some of the main things. I know it's going to be like a refresher for many of us too. All right. So, for instance, you're trying to investigate anemia in a patient. Okay, apart from getting the hemoglobin and the hematocrit, the rest RBC differentials are equally very important. Okay, so looking at the MCV, you can actually categorize anemia, okay, into normochromic normocytic anemia, microcytic anemia, or macrocytic anemia. So for instance, when you look at microcytic anemia, in which MCV is less than 80, in some instances, some people say it's 79, okay? Some people put their range 79 to 97. So if you just turn 79 the other way, it's 97. Okay, so any MCV below 79 is microcytosis. All right, so with that information, you can begin to determine what could be the likely cause of anemia in a particular individual. For instance, things that will make the MCV to be low will be things that will affect hemoglobin formation. So when you talk about chronic blood loss, all right, if somebody's losing blood, they are losing hemoglobin. Or in a way, they are losing iron. So over time, as the body tries to form more red blood cells, the iron content reduces. So you can tell if somebody has low MCV, you can begin to suspect, okay, maybe either this person has chronic blood loss or iron deficiency. And then looking at the age of the patient, okay, if the person is a female in reproductive age, you begin to think about iron deficiency due to maybe excessive menstruation and so on and so forth. All right. If the person is a man, all right, quite elderly, then you begin to think about things relating to chronic blood loss, maybe from the GIT and all that. And then you can tailor some of your other testing to be able to detect why maybe a fully grown man will be having microcytic anemia. Okay, so conditions that may cause a blood loss in the GIT. Then you probably want to order tests like fecal cord blood and so on and so forth. All right. The same thing goes for MCH because it tends to mirror MCV. Okay, so whatever affects your hemoglobin concentration would equally affect your whatever affects your MCV will equally most likely affect your MCH. Now, there is an instance in which low MCV can be normal. All right, so if you do a full blood count or CBC and the hemoglobin remains normal, but you have low MCV, then you begin to consider things like thalassemia traits, okay? Or things like hemoglobinopathy, because the red cells in things like sickle cell anemia, thalassemia, they tend to be smaller. And also they tend to come down with low MCV. Now, MCHC is gradually going out of vogue because it's not so abnormal in many conditions. One of the few conditions in which MCHC is low is what we call paroxysmal nocturnal hemoglobinuria. So what happens is that is a red cell membrane disorder in which part of the red cell membrane is chipped off as it passes through the spleen or the liver. So over time, the red blood cells become smaller and smaller and smaller. So the mean corpuscular hemoglobin concentration becomes increased. So when you see MCHC greater than 36, all right, and maybe coupled with a history of anemia and dark urine production, you can be thinking of this rare condition called paroxysmal nocturnal hemoglobinuria. So let me also quickly go to some factors that will affect CBC. All right. We have seen that age and gender affect CBC. Okay. People living in high altitudes can have higher red blood cell and then high hemoglobin. Hydration level, okay, can cause a fictitious high hemoglobin. All right. Pregnancy, there is a lot of changes that happen in pregnancy, including increase in MCV. So MCV can also increase in pregnancy. Not to limit things like folate deficiencies and B12 deficiencies that also cause an increase in MCV. So medications, especially antibiotics, chemotherapy. So let me, because I work in a cancer center, let me feel that CBC is usually very important when a patient is on chemotherapy. It's also a criteria that must be fulfilled before you put somebody on chemotherapy. And then when you put them on chemotherapy, it's something that you need to monitor because many chemotherapy agents causes what we call myelosuppression. So you need to monitor closely so that they don't develop anemia or they develop neutropenia or thrombocytopenia. Now, going gradually into the meat of the presentation for today, let's look at the historical perspectives about evolution of a full blood count. So in 1952, Karl Wiedroth, who was a German physiologist, introduced, sorry, 1 minute, counting of red blood cells, all right? In fact, he is the one that actually discovered, he started the concept of peripheral blood film analysis, okay, spreading blood on the slide and looking at it under the microscope. So in 1874, hemocytometer was invented by Louis Charles Malasses, following quantified measurement. So over the years, hemocytometer was developed. I don't know how many of us have seen the hemocytometer before with the counting chamber. I don't know. I didn't use it in practice in any way, but I trained with it when I was in medical school. All right. We actually did practicals using hemocytometer to, count red blood cells, also platelets, and we actually had exams on them. Okay. It can be very tedious, manual procedure. You'll be making dilutions and so on and so forth. There is a picture which I will show you for those who have not seen it before. All right. Significantly, in 1879, Paul Ehrlich, as all of us will remember, developed and applied dyes that discriminated leukocytes by their staining property. So this really made a significant impact in the evolution of the full blood count, in which case with stains, you're now able to differentiate the various components of the full blood count, especially the white cells. In 1885, a Swedish physiologist, Magnus Bliss, invented, and Gustav Hedin, both at the University of Lund, further developed what we call the hematocrit device, which is used to measure the packed cell volume. The hematocrit as a terminology was actually derived from lactocrit. For those of us that know about Sweden, they have a lot of cows in which they harvest milk from the cow. So in order for you to know the quality of the milk, you need to measure how much of the solid component of the milk. So if you spin that milk itself, okay, you have a pot that is floating above, okay, the liquid, and then depending on how much of that will determine the quality of the milk. So it was from that concept that hematocrit was developed, but in the reverse, because when you spin down your microhematocrit, the solid part, which is the reservoir, is actually below, and the liquid part is above, and in between, you may have the buffy coat. So this is just a picture to show us the hemocytometer, okay, the Newberg counting chamber, as many of us that can remember, okay. So maybe some of us used it. All right. So it's just of historical importance. You will not find this used in practice anymore. Okay. Anybody that is using this, they belong to the Stone Age. Now, a little bit more on the historical aspect, but just because of time, let me quickly go to what happened in 1953. So, Miss Wallace Coulter actually developed the impedance measurement. Okay, so Mr. Wallace Coulter happens to be an electrical engineer. So he was working with some electronics engineering company, and he used to work in the Far East, in Japan, South Korea, that axis. So following the Second World War, he noticed that uh, victim of the bomb blast, they needed to monitor their blood count quite frequently. All right. And he noticed that physicians were going through a lot of stress for you to be able to do manual uh, CBC analysis. It will take you several hours to be able to do a manual CBC analysis. So alongside his brother, Joseph Coulter, they started experimenting with the photo detector, and they were able to find out that uh, when you subject if a cell passes through a tiny aperture, it alters the impedance of the electrical circuit attached to the equipment. All right. So with that, they came up with some ideas about how to use automation to measure blood counts. After that particular episode or instance, a number of further technological advances happened, culminating in fluorescence-based flow cytometry. Today is not for flow cytometry. I believe that will come on another time. But the major work, the major improvements in technology with respect to automated CBC measurement came with Coulter and his brother. So after a couple of experimentation, Mr. Wallace Coulter and his brother came up with the very first automated full blood count machine called the Model Coulter counter. All right. So this is the picture of the Model Coulter counter. This was actually they got a license to produce this in the US, and they presented it at some congress in the US then. After a series of improvements over 14 years, they were able to come up with the Model S Coulter counter, which was released in 1968. Now, the advantage is that apart from the accuracy, this offers above manual complete blood count measurement. It also reduces the time it takes for you to be able to generate a complete blood count. All right. So with the release of the Model Health Scooter counter, all right, a significant edge was developed in laboratory practice, optimizing measurement of the complete blood count. Following this, a number of new methodology arose, and then we now have what we call the 3-part, the 5-part automated hematology analyzers. Now, of importance to discuss today is the Coulter principle, which was mentioned in 1948. It says that particles put through an orifice coincident with an electrical current produce a change in impedance proportional to the volume of the particle passing the orifice. All right. So it means that if you have a single cell passing through an aperture or an orifice, and you pass an electrical current, okay, at the same time the cell is passing through the aperture, okay, it produces a change in the impedance. Fortunately, impedance can be measured. Okay, so with this, you can actually now say that as the cell is passing, if there's a change in the impedance, then you can count the number of cells that is passing. Then depending on the amplitude of the change in the impedance, you can also say this is the likely volume of the cell that has passed through the aperture. So this is the basis for modern day hematology analyzer and even flow cytometry. Okay. Now let's look at briefly at the automated 3-part analyzer. So, like I've said, it uses basically impedance to differentiate WBC into granulocytes, mainly neutrophils, lymphocytes, and mid cells, which are monocytes, eosinophils, and basophils. And this is purely based on the cell size. Okay? Impedance essentially means resistance to passage of current. Okay? So you can actually measure that resistance as a cell passes through the circuit. Okay, so for the automated 3-part analyzer, the basic mechanism it uses is purely impedance based. So it can only measure or make counts based on the cell size. All right, as each cell passes through the aperture, there is an alteration in the electrical impedance, and this can be counted. Okay, so if 10 cells pass, you can see a change 10 times in the impedance. Also, depending on the volume of the cell that passes, then you can see how much of impedance has occurred. All right. So with these two basic observations, so we can make a count of the number of cells that passes through the aperture, and you can also make a differentiation of the type of cells that pass based on the volume of the cells. Okay. Now, so this is just a simplified diagram of what I've been trying to explain as the basic principle of the 3-part hematology analyzer. So if you look at the picture on your left, all right, it talks about the cells being aspirated into the system. Then it will come to part of your analysis, the fluidics part of your analysis, or your what do you call it now? Your cleanser, your probe cleanser, to remove all the abnormal proteins in the system. Then you need your diluent, okay, to suspend the cells equally, okay, and then you need your difflies, okay, to remove the abnormal, what you don't need, for instance, essentially the red blood cells. So when it comes to analyzing your white cell differentials, so you want to lyse all the red blood cells in the system, so that you know that you're dealing with just white cells alone. Okay, so now the system is such that you are able to isolate individual white cells and then make them pass through the aperture, as you can see in the middle of the diagram. Okay, as the cell passes through the aperture, an impulse is generated. Okay, all right, and then using a lot of photodetectors and electrical circuits and algorithms, so you can make a count of the number of cells that are passing, the white cell count, the red cell count, the platelet count. Okay, and then for the white cell count, you can make a differential count of what has passed. Okay, how many, in terms of percentages, how many neutrophils have passed, how many lymphocytes have passed, and how many mid cells have passed. Okay, so this is a very, very simplified, all right, this is a very simplified diagram. Okay, it doesn't speak to the electrical, computations, algorithms, and the wiring of the automated system. All right, but also know that even though this is just a basic diagram, the automated analyzer, whether 3-part or 5-part, is a very sophisticated equipment. Okay, it's a very sophisticated equipment. A lot of improvements have been made. Many technologies have been borrowed from other areas, including mechatronics, okay, hydraulics, how the system sucks in your sample, how it analyzes, mixes all the various fluids, diluents, difflies, and so on and so forth. Okay. Now, the practical applicability of the three-part analyzer, okay, it is generally considered to be accurate and precise. We will see when we look at real-world analysis of abnormal fluid count especially, okay? So it is accurate and precise. However, in abnormal situations, when you have samples with relative cell count and morphological appearance of cells may be altered, the more advanced 5-part differential analyzer shows superior performance. So it is not that the 3-part analyzer will not give you a result. It will give you a result, but the exactitude that you need, especially when the sample is abnormal, okay? Because you cannot tell what sample you are going to receive. In many instances now, people don't tend to go to the hospital unless things are really very bad, okay? So it's at that point when they are presenting to you, that's when they are actually getting the abnormal blood counts, okay? So relying on the 3-part count can be a bit challenging, even though it will give you some of your parameters in an accurate and precise way. Thus, it is generally accepted that only generating a 3-part differential for pathological samples is not ideal. So in this age and time, hardly would maybe a doctor want to entertain just a 3-part differential because a lot of things can be missed, all right, if you're just relying on a 3-part differential. All right, but we're going to make some comparison in some of the later slides. So let's go to the 5-part analyzer rather. Now, in addition to impedance, the 5-part instrument employs principles of flow cytometry to differentiate WBC into the 5 major subpopulations based on cell size and complexity. Now, to talk briefly about flow cytometry principles. So basically, it is just an improvement in the discovery of staining of cells, generally speaking, all right? So it involves deployment of dyes or monoclonal antibodies, as it were, okay, to distinguish cells. So when you treat white cells to different dyes, okay, you can pick each of these cells apart from the other. For instance, reticulocytes tend to have a lot of remnant DNA and RNA in them, okay? So if you treat them with dyes that can attach to RNA and DNA, you can optimize your analyzer to be able to detect reticulocytes. And even beyond that, there are even further parameters that you can derive from maybe checking your reticulocyte. I don't know how many people have seen reticulocyte hemoglobin being done before. Depending on the sophistication of your analyzer, some very high-end analyzer can even give you reticulocyte hemoglobin content. And you can even use that to be able to say, okay, this person has iron deficiency anemia without even going forward to do things like iron studies. All right. So essentially, in the flow cytometry principles, you want to attach maybe a dye or a monoclonal antibody, taking advantage of the content of the cell, all right, to be able to differentiate that cell from the other. So in flow cytometry principles used in 5-part analyzer, cells pass in a single file through the aperture surrounded by sheet fluid. Everybody will now remember their sheet fluid as apart from the diluent, apart from the difflies, the cleanser, then you have the sheet fluid that helps to maintain the cells in a single file as they pass through the aperture. All right. So as they pass through, the cells are exposed to a fluorescent dye. Okay. Then a laser beam is passed on this same sample as they pass through the aperture in a sensing zone. So the light scattering and fluorescence of the cells is now captured by a photoconductor, all right, in a mechanism described as adaptive cluster analysis system, Okay, depending on the type of equipment you are using, various technologies may be deployed in the system. For things like 6-mess, you have adaptive cluster analysis system in them. So the number of generated impulses then correlates with the number of cells, whereas the light scatter is used to determine cellular granularity, shape, and size. And so with the analysis of these features, then you can determine further more than what the 3-part analyzer will do to be able to generate your
Engineer,
neutrophils, lymphocytes,
engineer,
monocytes, eosinophils, and basophils. So this picture is actually showing a simplistic view of what the 5-part analyzer does. Okay, so if you look at the picture on the lower picture on the right, on your left, okay, it talks about the laser beam being directed on the cells that have been treated with fluorescent dye, and they are emitting a low scatter, medium scatter, or signal, or high signal. Each of these can be used to sort of define the properties of the cell that is passing through the apparatus. So the low signal or scatter is utilized to determine the size of the cell. All right. The medium scatter medium scatter or signal is used to determine the cellular properties, the nuclear properties of the cell, while the high scatter or signal is used to look at the granularity, okay, or the complexity of the cell. So with this, you are able to now, using cell sorter, differentiate the different cells in the 5-part analyzer, and you can actually separate them, okay? And then once you capture the signals with the photo detector or scatter detectors, then you can plot a graph of the fluorescence against the size scatter. Then you can generate a signal that can really show you, okay, this is the amount of neutrophils you have, the amount of lymphocytes, eosinophils, monocytes, and basophils. All right. Now we have more advanced systems, especially when you talk about the flow cytometry, in which you can actually separate this cell components. So if you want to harvest all the neutrophils, you can actually harvest all the neutrophils. You want to harvest all the lymphocytes, you can harvest all the lymphocytes, but that's for another presentation. So in terms of applicability, the 5-part analyzer has better diagnostic ability. It provides a more superior clinical insight and also has extended capability with more useful parameters. So the 5-part analyzer can be optimized more to generate even more what I can call indices on your full blood count. And that has created a new problem, in which case people now are beginning to question how many parameters do we want to generate on our full blood count. You see some full blood count, maybe they have 16 parameters, you see some 13, you see some 22, you see some 28, and so on and so forth. And questions have been raised as to the usefulness of some of these parameters now. So the more technological advancements we have made, then we're having more, is it confusion in quote now with the kind of parameters we are generating. And in the overall, you want to look at what is really relevant, okay, to the patient in the clinical setting. So I briefly did a comparison, okay, of 3-part versus 5-part. In terms of precision, both are good. But for accuracy, the 5-part analysis tends to be better, all right? For instance, if you have a sample that, okay, the mid portion of a 3-part analyzer is increased, okay, when doctors see that, we're a bit concerned because abnormal cells tend to have larger size, okay? They tend to be larger. So if you see a mid proportion or percentage of your three-part analyzer reading about 10-15%, we are so much bothered, because you cannot make a headway without doing a peripheral blood film to be able to, okay, sort out that particular situation. In terms of cost, the three-part analyzer is cheaper. It also equally uses less reagents, while the five-part may cost more and uses more um, reagents. In terms of diagnostic capability, the three-part is limited while five-part is improved. Clinical utility is better with the five-part analyzer. And in terms of requirements for you to do blood film, the three-part analyzer would require you to do more blood film analysis. All right. Why the five-part analyzer? It will be only when it is indicated. So that means the sample must really be abnormal before, maybe a blood film will be required with your five-part analysis. And if you have to do blood film, then you require more technical skills, you require more resources in addition to your three-part and so on and so forth. So if you are using a three-part and you are in a situation whereby many of your patients have complaints, they have, symptoms and signs, you will be having a lot of abnormality, especially with your mid components of the three-part analyzer, and then that will call for more peripheral blood film analysis. So if you are going to look at the clinical value of your five-part CBC differential in modern practice, it has ability to demonstrate exactitude in routine analysis of blood counts. It has robustness in analyzing samples with abnormal cells, as we have seen during the discussion. It also reduces the need for frequent blood film examination, and equally, additional functionality with useful clinical value can be added to your five-part analyzer. So it allows more room for you to be able to get more derivative parameters that will be of useful clinical value, all right, especially for the patients. So I did an experiment which I will share with you over a few days, a couple of days ago. So I had samples done on both five-part and both three-part and five-part analyzer. So we're going to look at some of the differences that were generated. So this is sample from a patient, sorry, yes. So this is samples from a patient with complaints in a cancer center. I wouldn't want to give more details. All right. So I subjected the same sample to both a three-part and a five-part analyzer. All right. If you look at the WBC, sorry, I can't capture all the parameters, things like MCH, MCHC, platelets, derivative parameters. I couldn't capture everything because of space and time. All right. So if you look at the FBC, the WBC, 20.2 on the three-part, 20.7 on the five-part. So you can see that there isn't much difference. If you look at the neutrophil, there's a bit of a difference, okay? For the three-part is 11.6, while the five-part is 13.2. Lymphocyte 6.1 on the three-part, 6.5 on three-part, and 6.0 on the five-part. Not much of a difference. Monocyte, a huge difference, 2.1 on the three-part and 1.3 on the five-part. So you can see that the three-part has matched what you have for the monocytes, eosinophils, and basophils together. All right. Hemoglobin 8.6, 8.4 respectively, not much of difference. MCV rather, 75 versus 73, not much of a difference. Platelet equally 60 versus 56, and not much of a difference. But in the analysis of the differentials, that is where you see the three-part analyzer not really giving you exactly what you need. And this can become significant in a setting whereby a patient is going to become neutropenic, for instance, where a difference between difference of 0.2 can be quite significant. So if somebody has a 0.8 neutrophil, that person is termed neutropenic, and you will need to intervene, give some medications to boost white blood cell counts. If the neutrophil is 1.0, all right, you really do not count that person in the cancer setting to be neutropenic, and you may have to go on with your treatment, or you may have to just support. Okay, so it can really, at the very thin lines, it can really make a difference. So this is the second sample I subjected to this experiment. All right, so you can see there is leukocytosis in this sample. WBC, not much of a difference. Neutrophil, you can see the major difference there. So it is in that mid segment that we have a major difference in the analysis. All right, lymphocytes 1.4 to 0.9, monocyte 2.0 to 0.6. So what you would have termed 2.0 or 2000 is actually 0.6 in terms of monocytes, while other parameters have been added together in the mid segment of the three parts analyzer. So we can see where the little difference, which can be significant in the clinical setting, is in comparing 3 parts and 5 parts analyzer. Let me quickly conclude now. So in terms of modern clinical practice, which requires reliability, the five-part analyzer provides enabling quick and precise analysis of blood cells without mincing words, with exactitude, and you are sure what you're dealing with. Thank you very much for listening, and these are the references. Thank you. Yes.
Well, thank you very much, Dr. Femi. This has really been insightful. Okay, so we have some questions in the chat box, so I'll just read them out and then, have you answer them.
Okay.
So first off, the first question we have is from Onyinye. And Onyinye says, what is the difference between hemoglobin results measured using a capillary sample, that's a finger prick, compared to those obtained from an automated hematology analyzer, that's venous blood machine? She says, I'm thinking it should be venous blood collected. This question is because I have noticed capillary being lower than that of the machine by 2 or 5. That's what Onyinye is asking.
Okay, should I go ahead one after the other?
Yes, please.
Okay,
Yes,
all
please.
right. So for the capillary hemoglobin sampling, you know that there's a difference in the samples you're taking, all right? First, you're taking a capillary sample, okay, versus a venous sample. That in itself can make a difference, all right? The venous sample is almost always preferred. In fact, it's the standard of care, all right? It's the standard of care. Simply because of some of issues you have with determining the exact hemoglobin concentration in your patient. Okay, so the other problem is that the hemoglobinometer, as it were, is not as advanced as the automated analyzer. So apart from difference in the samples that you're taking, there is also a difference in the methodology. Okay, so that can account for the differences you have in the results that you get. Now, deploying these, you should know that the standard of care is venous sample on a hematology analyzer. That's the standard of care. In a situation, maybe in an emergency setting, in a screening setting, maybe you can deploy your hemoglobinometer. But for patients you're going to be treating in the hospital, all right, your standard of care is venous blood and a hematology analyzer. I hope I've been able to address your concern. Thank you.
Okay, so if I get you right, standard practice should be using venous blood because that shows
Yes,
us a true picture of what's happening within the patient's body.
yes, yes, correct.
The next question is from Stella Chima, and the question is, what challenges do laboratories face when transitioning from 3 parts to 5 part analyzers?
Okay. All right. Some of the challenges have been highlighted during the presentation. Okay, so if your lab is trying to switch from a 3 part analyzer to a 5 part analyzer, all right, first and foremost, you need to look at what is the goal the lab is trying to achieve, okay? You should look at your clientele, all right? You should look at the category of patients that you receive in your lab or the kind of samples that you receive in your lab, all right? Now, in terms of cost to your lab, the 5 parts analyzer will definitely cost more than the 3 part analyzer in terms of the deployment of the equipment itself, in terms of reagent requirement, all right? However, in the long run, when you switch to a 5 part analyzer, you have more accuracy, more reliability, and it will reduce the need for you to be doing peripheral blood films. If you're using a 3 part analyzer in your lab and your mid segment is a lot of the time high, ideally you should carry out a peripheral blood film on that sample because you may be missing acute leukemia or in fact a leukemia, whether acute or chronic leukemia. All right. And if a lab misses leukemia, all right, though you have done the full workout, if a lab misses leukemia, then your practice is going to be called into question. Okay, so you will not want to miss something very important, which can actually affect the image of your lab. So in the overall, deploying a 5 part analyzer is modern practice, okay? It is less problematic, it is more clearer, it provides a lot of accuracy, and reduces the need for you to be doing peripheral blood films. So those are the things that you should look at for. Challenges in terms of more costs in deployment of the equipment at the initial time, all right? In the overall later, there's no difference in terms of maybe the lifespan of the machine or the problems you're going to encounter. No, not necessarily there's going to be a difference, but that you need a bit more reagents, okay, than the 3 part analyzer, all right? But it gives you the opportunity to produce reliable results. Okay, so if I'm going to be voting for your lab, I'll be voting a 5 part analyzer, not a 3 part analyzer. Thank you.
Okay, doctor. Okay, so let me ask my question before I ask the next one in the chat box. Okay, so you've mentioned that it's possible that we could miss out leukemia, whether it's acute or it's chronic. Could there be other things that you could probably miss out on? Because as you were answering, you mentioned that for one to transition, they need to look at their clientele. So is there a clientele that is allowed that, oh, 3 part is sufficient? I mean, people are walking around, like you said, they only come in when they are feeling really down. So if we are just going to say, okay, let me just rely on my 3 part, is it not possible we are going to miss out, very essential things? So what clientele should we be looking out for if we are saying that, okay, 3 parts are good, but they are not good enough? Shouldn't we just say that, okay, we understand that you're trying to do your 3 parts, you're trying to manage, but at the same time, you could miss out something very important that the person may not be showing any symptoms, just walks in. And because you're using a 3 part, you miss out on that. Which other settings would the 5 parts be more ideal in? I know that you're in the oncology setting presently. Are there other settings where a 5 parts would be a yes or a yes?
Okay, all right. Thank you for the question. Um, if you have seen the way I've handled this discussion, my preference is 5 parts analyzer. Okay, it provides more information to me. With the 5 parts analyzer alone, I can actually make a diagnosis without even probably examining the patient or doing any further test. There's a lot of diagnosis I can make with a 5 parts analyzer. Now, if you check the literature, what is said is that maybe the 3 parts analyzer might be useful in the setting of what we call routine annual checkup. Okay, somebody that is fine, has no complaint, they just want to do a routine medical check. Okay, but I will use an example for those of us that like football. There's a Nigerian footballer about 5 years ago. He just went for his annual medical checkup, and they noticed that some parameters were not looking, they were a bit abnormal. Okay, so they asked him to come back, uh, did some further testing, and he was diagnosed with acute myeloid leukemia. All right, even though he was well in himself. All right. So eventually, then he got treated and he went into remission. I think he's fine, he's alive and well. Okay. Now, even with the routine annual or medical checkup, you can still miss important things with your 3 parts. Okay. All right. So you cannot do a 3 part differential without a peripheral bluffing. Just for me to be clear, okay, you cannot do a 3 part differential and go away with that. Okay, you must do a peripheral bluffing to cross-check what you have done. Otherwise, you are going to miss something. Now, let's look at other scenarios. For instance, in the pediatric setting, okay, children, you don't want to just offer children a 3 part differential too, because that is the setting in which acute leukemia is most common. Okay, so if a child would have to do a full blood count, you won't want to offer just 3 part analyzer without a peripheral bluffing. Okay, but if you're able to do a 5 part analyzer, you can almost always say 99% of the time that, okay, this blood count is normal in itself, and a peripheral bluffing will now be indicated. However, if a 5 part analyzer picks up abnormal findings, of course, then a peripheral bluffing is indicated in that instance. So, if you have noticed, 3 parts analyzer, well, you can manage it, but then it can come back to bite you in the back sometime later. Yes.
Okay, thank you. So 3 parts can be managed, but it can come back to you, come back to bite you. Let me use Dr. Femi's words. Okay, so the next question comes from Alfred Martin and is asking, please, how does the analyzer determine abnormal cells or abnormal cells in this context? Okay, is it pre-programmed to consider an ideal size of red cells and hence eliminate those when performing the analysis? I don't know if you got the question.
Yes, I do.
So,
Okay. Yes. All right. So when I was talking about the 5 parts analyzer, especially the clinical benefits, okay, let me just quickly go down to so if you look at the last value, additional functionality with useful clinical value. So the 5 parts analyzer is a little different from the 3 parts analyzer, in which in a situation whereby there are additional functionality, including flagging systems. Okay, so if you have an abnormal cells running through the aperture, especially the 5 part analyzer has additional functionality that can flag abnormal cells. Okay, so at times, depending on the sophistication of your equipment, they can even tell you that it's a blast based on the functionality that have been inbuilt into the analyzer. So you see some printouts, it will do some interpretation, lymphopenia, lymphocytosis, neutrophilia, and some, they will put query blasts. So that is the additional functionality that the 5-part has above 3 parts, okay? It can actually figure out cells that may resemble abnormal cells, okay? Then when you see that, then you know that a peripheral blood film is mandatory in that particular instance. It is not only blast cells that they can flag. There is a condition called infectious mononucleosis, caused by Epstein-Barr virus. I believe all of us will know about Epstein-Barr virus. So it tends to cause a lot of abnormal lymphocytes, even though they are not leukemic cells, but they are just abnormal. They can be large. It can cause monocytosis and all that. So the 5-part analyzer is also equipped to be able to say, okay, this is a typical lymphocyte. There is monocytosis. I'm sure some of us would have seen all that before, okay? So there is additional functionality on the 5-part analyzer, including flagging systems, okay, that can give you more information than what the 3-part analyzer will give you.
Okay, so this goes on to ask that how does the 5-part able to suggest conditions in some analyzers? I'm sure you've been able to answer that. The
Okay.
flags and
Yes. So all those flags are basically algorithms that have been inbuilt into the 5-part analyzer based on the analysis of the features of the cells that are passing through. Okay. So a combination of those features in terms of abnormal size, abnormal granularity, okay, unusual nuclear configuration. So based on those parameters, algorithms are built to be able to say, okay, this is an abnormal cell. So once any cell fulfills some of those criteria, the algorithm will flag it as an abnormal cell or a blast or an atypical lymphocyte and so on and so forth. At times, you could have even non-hematological cells passing through. There are some childhood cancers that they can disseminate into the blood. So you would think that they are leukemias, but they are actually not leukemias. So we call them round blue cell tumors. Okay, the sarcomas, rhabdomyosarcomas, neuroblastomas, especially in neuroblastoma cells, they can actually disseminate into the blood. What you just see is lymphocytosis, okay? For the regular analyzer, you just see lymphocytosis and all that, but they're actually non-hematological cells. So advanced uh, 5-parts, 5-part analyzer has additional flagging system to be able to say, okay, these are abnormal cells going through the systems, and then you can also now look further into that.
okay. Before I ask, we have some more questions, but let me ask my own. I have the privilege to ask. So I was talking to someone a while ago, and I was trying to, get them to, see the need for a 5-part. And the person said, and I quote, many doctors do not bother with a 5-part. They are okay with a 3-part. I mean, they say they have their way of calculating the cells that a 3-part can miss. I'm glad that we have you in the house, sir. Please, is that true?
Okay, so that is not true, but I don't see it as I don't think it's as a doctor-specific problem. It's a general problem. A couple of days ago, we were at a meeting in Lutz. Maybe I can stop sharing now, right?
Yes, please. Yes, you can.
Okay, right, okay. So we were at a meeting. Okay, sorry, just give me a minute. My battery is going down. Let me just connect to my charger now, please.
Okay,
Okay,
then. All
just,
right.
just a minute. Thank you.
Okay, so while Dr. Akinwunmi is getting his charger, somebody asked, how can we get the recorded session? So the the recorded session will be put out in our website much later. We'll have it out there, and we'll also share. We'll do some follow up with those of us who are on this call. So we should be able to get that, but we should be able to share the recorded session after this conversation. But just in case we do not, you can reach out to us. Okay, Dr. Femi is back.
Yes, I'm back. Thank you. So, so the question is about some doctors saying that they have a way of calculating their, differentials from the three-part analyzer. Well, really, for the mid segment, there is no way you are going to calculate anything. It's not possible. Okay. Now, but it's not just a doctor-specific problem. I think it's a general problem. So I will give you an instance. So we're at a conference a couple of days ago, and there was this conversation about antibiotic sensitivity, all right? So a research was done. It was actually at Ruth that only about 5 to 10% of doctors utilize antibiotic sensitivity pattern to give antibiotics to their patients. Can you imagine that? You know, how can a doctor say that more than 80% of doctors say that they don't utilize antibiotic sensitivity pattern for treating patients who require antibiotics? So it's more like an attitudinal problem, okay, and it's a general issue. It's not just about one particular individual. Now, because we are used to a low resource environment, okay, a lot of these ideas or concepts that people project are actually signs of low economic values. All right. If you are in a setup in which excellence is the key and resources are not a problem, all right, the five-part analyzer will not be will not be a challenge. Okay. So like I've been saying, you can only manage the three parts. There are instances you will miss major diagnosis using just three parts alone. But you don't want that to happen at all. You don't want that to happen because uh, even though it's one person, it's 100% for that particular person. All right. You don't want to misdiagnose a client. Yes.
Yeah, I got that one. Even if it's one person, it's 100% for that person. That makes a lot of sense. So, doctor, we have seen how important this is. We have seen how we can save lives. The example you gave of that footballer that did a routine test, and the leukemia lymphoma was picked up early, and today he's alive and well. So it's really important. We can see that. So how do we bring this message home? How do we make sure from our own end? I mean, we can't force it down. Maybe clinicians, labs, diagnostic centers, hospitals, clinics. We can't force it down their truth. But I mean, how else can we do better to send this message home, saying that it could be 100% for that one person? What should we be doing that you think we are not doing yet?
Well, I believe that the eminent people on this call, I think they are the target audience, if you ask me. Okay, and usually when it all boils down to cost, okay, it all boils down to cost, especially at the time when maybe a diagnostic center is being set up, a hospital is being set up, and also depends on the kind of advice that owners, proprietors are being given. Okay. Uh, Personally, I believe that when we uh, sing the message of the five-part analyzer, a lot of people seeking advice on what to do, especially when setting up a diagnostic center or a hospital. When you get the right advice, there won't be any problem as to deciding on getting a five part or a three part. I would always say that the three part is problematic for me. I find it quite challenging, especially if if I'm in a place whereby I cannot do a peripheral bluffing. But like I've said, you cannot issue out a three-part result without bluffing commentary. Okay, you must do bluffing commentary to be sure that there are no abnormal cells in circulation. So I want to employ everybody on the call because we are mostly the ones giving advice to people when they are setting up their diagnostic center or a hospital or whatever setting. It might just be a standalone clinic. Okay, when we are giving advice, let's encourage them to uh, start up with a five-part analyzer. You know, people are now even talking about 7 parts and so on and so forth. But let's just stay with 5 part first. Okay, let everybody do um 5 parts. All right, and I believe that it's going to go a long way in avoiding missed diagnosis. Okay. Yes. Thank you.
Thank you, sir. So I think we just have two more questions in the chat. And Chidima says, please, there was a time you were speaking about aperture. It wasn't clear.
Oh, okay. Aperture. Aperture is just an opening. Aperture means an opening. So in the analyzer, the opening can only accommodate a single cell at a time. So that is where the cell passes. As the cell is passing through that opening or aperture, a current is passed through the aperture. Depending on the size of the cell, impedance is measured, okay, and then you can now do your calculation. So if a cell passes, you know one cell has passed, and then you can gauge the size of the impedance, and then you can determine the size of the cell. So if two cells pass, two signals will be picked, okay. So aperture just simply means an opening. That is where the cell will pass. A single cell is only allowed to pass at a time, and then you can do your measurements in the analyzer. Thank you.
And shows are normal. What are we expected to do? So, ISN, of course, get you who would help with that. Let's not bother Dr. Akinwunmi with their technicalities of their functionality. So you can reach out to us on our toll-free lines, and our technical team will reach out to assist you. Now, Alfred is asking, how relevant is the CBC scatter plot in clinical diagnosis or care?
Okay, all right. Yes. So maybe not much for the clinicians, all right, but for the laboratory person, the scatter plot is equally important. So it's something that you can use to exclude abnormal cells in your sample. You can also use to correlate the result that you have gotten from your sample. So for instance, if there are abnormal proteins in your sample, okay, it may alter what your results from the printout is, okay, but you may have a normal distribution on your plot. So for instance, there are certain conditions in hematology that makes people to produce abnormal proteins. One of it is called multiple myeloma. Also, HIV may be associated with production of abnormal proteins, okay? So when you have abnormal proteins in the sample, it can alter the way your result comes out. For instance, one of the most common ways is that you may have a discrepancy between your hemoglobin concentration and your PCV. So you may see hemoglobin concentration of 30 and your hematocrit will be 21. Okay. All right. You can see that there is a disparity. Sorry, your hemoglobin concentration is 10 rather, and your hematocrit is 21. So what you would have expected is that your hemoglobin, your PCV from that hemoglobin concentration of 10 should be 30 or thereabouts. But what your hemoglobin concentration is giving you is 10, which is the correct result because hemoglobin concentration is the standard measure, not PCV. PCV is the derivative. Okay, so hemoglobin concentration is the direct measure for anemia or blood level. So you have hemoglobin concentration of 10, but your PCV is reading 21. So, and that tends to happen when you have agglutinins in your sample, all right? So what happens is that the red cells are clumped together. So when the analyzer does its an algorithm and derives the PCV, your PCV is low, but actually the patient's hemoglobin concentration is normal. So the blood level is actually normal. Now, so you can also have that with white, it can also affect your white blood cells and all that. So your scatter plot can help you to delineate things in your sample that can affect your results. Okay. So the scatter plot is actually like flow cytometry. Okay. It's a very highly sophisticated output and is highly very specific. So it's derived from cells that have been treated with either monoclonal antibodies or dyes. So you can use that like what we call quality control. Yes. So like internal quality control. Okay. So you can use your scatter plot to analyze the results you are getting. So it's mostly for you working in the lab rather than for the clinicians.
Okay, so this your question has brought another question to my mind. And when you were speaking earlier on, you're talking about having certain number of parameters. Some systems do 18, some 22. And we begin to ask ourselves all these plenty parameters we are packing. Which one are we facing? Which one are we doing or not doing? So now the question is, do laboratories, hospitals, clinics, diagnostic centers, do they always utilize the full potential of a 5 part? Is there still any gap in interpretation? Is there anything, you can have a 5 part and you just use the result and you don't even understand what it means. You just need it because you have it. Is there still any gap in interpretation?
Okay. Yeah, okay, I will take it this way. Maybe quite a number of diagnostic centers do. Maybe quite a number do not as well. But what I've found out is that many doctors, generally speaking, may not be able to read some of the parameters and make uh, clinical, uh, gain clinical information from many of the parameters. So they just want to what they know and then off they go. All right. But for people in the lab, we can make a lot of interpretations from from a single full blood count. Now, here comes the question of what is really important, okay, especially for the patient. Okay, so there have been a lot of arguments back and forth on what is important. But I've seen both ends. I've seen 9 parameters, I've seen 28 parameters, and I know the value of some of the extended functionality that you can get in your 5 part analyzer. So each lab has to make a determination of what is relevant to them, what is relevant to their clientele, or to the hospitals that they serve. Okay, and that should determine the parameters that they include in their full blood count or CBC output. So I would not categorically say that, okay, one is better than the other. I think it should be based on who is being served, what is relevant to the situation at hand.
Okay.
Thank you very much, sir.
Hello, Dr. Akinwunmi.
Yes, please.
Yeah, so sorry, I had a little bit of issues with my laptop. So, but I'm here. So we have one question in the chat box, and the question is from John, and it says, what limitations in terms of diagnosis can we encounter in the use of both 3 and 5-part analyzers without examining blood film?
Okay. Okay. Well, the import of the question is not so clear, but I'll try and make an attempt. All right. So if you're using a 5-part analyzer, I don't see a reason why you will need a 3-part analyzer. All right. But for any full blood count that you are doing, even if you're using a 5-part analyzer, the 5-part analyzer is empowered to flag things or do flag abnormal counts, as it were. So if a blood film is needed, it will almost always be easy to know that, okay, this sample needs to have a blood film checked, okay? If you're using a 3-part analyzer, it will almost always be incumbent on you to accompany it with a peripheral blood film review, okay? Because you might have missed something because of that mid segment that is not able to differentiate uh, 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 some of the cells. Okay, so on a 5-part analyzer, if there are no flags and everything looks normal, preferably you will not require a peripheral blood film. But if there are flags, especially in the YCS segment, then you would need to do a peripheral blood film, or if patient has thrombocytosis or thrombocytopenia, okay, you would need a peripheral blood film. Generally speaking, for anybody with anemia, you need a peripheral blood film review.
Okay. Thank you very much, Dr. Akinwunmi. In case anyone has any questions that you'd like to ask, please you can unmute your mic and ask. I've exhausted the questions that are currently in the chat box. Yeah, Kingsley, you're unmuted. Do you have a question? Kingsley Enuma, you are unmuted. Do you have a question, please?
No, sorry.
Okay. Okay, yeah, Adeni, you are raising your hand. Please go ahead and ask. Okay. We don't seem to have any more questions. Okay, Dr. Femi, personally, I have learned a lot from this session, and I believe that everybody joined in on this call, and people who would have access to this information much later after this conversation would definitely have a thing or two to learn. We want to thank you for your time and for sharing your knowledge with us. Thank you for impacting us, and we hope that together we can, advance and, create excellence for the patients. I mean, the patient could be anybody, could be me, you, I mean, our relative.